Good evening. Thank you, Dr. McKay, for the nice invitation, and welcome everybody in our country. I come from Rome. It's not so far from Milan, but I hope you could enjoy your experience in our beautiful country. My first approach with ACL repair was after this beautiful day I spent with Bertrand, my friend Bertrand Sonericote, just after his surgery on the skier, Czech Republic skier, who could come back to the Olympic Games 4 weeks after ACL repair, and he motivated me a lot, as usual, to start this kind of surgery in my country. So when I went back, I think I was one of the first in my country to start performing ACL repair. The goals of ACL repair are clear. The goal are to try to make the ligament heal rather than replace it with the tendons, and so restoring anatomy and function of the ligament and of the joint, and for sure also preserve the sensory and proprioceptive function of the ligament, and last but not least, avoid harvesting related morbidity. But as we saw this morning, many papers in the 70s and the 80s, when ACL repair was the only solution for all kinds of injuries to the knee and to the ACL, showed half of patients with bad results and deterioration of results during the time. But if we want to be pessimistic, if we want to be optimistic, they also had 50% of good or very good results on their patient in an era where surgery was open and with different limitations. By the way, at that time, the ACL was considered not capable of healing after this early and old experience on ACL repair. But when I looked at this paper, when I had to present a lecture on the history of ACL repair, I saw that all these papers were based on some limitation. All the surgeries were open, post-operative protocol was with a prolonged casting. The suture material were very low biomechanical properties of suture. They lost a lot of patients at follow-up, and last but not least, again, the rash selection of patients. So they include patients with every kind of ACL tear and every kind of associated lesion. So they had big limitation when we need to look at these results carefully for this limitation. Moreover, technology and technique have evolved during the last years, such as for other devices. We started with open techniques, and we now have different devices and different techniques to perform ACL repair in arthroscopy. Moreover, we well know that the ACL has an healing potential that it was clearly demonstrated by several animal studies and human studies. There are 4 different phases of ligament healings. The problem of the ACL is that the environment, so the interarticular environment, is an adverse factor for healing, and so without surgical repair, the ligament retract and bends after injury, and so sometimes it heals, but in a non-anatomical and so non-functional healing. So the goal of repair is to fix again the ACL in its anatomical position, to allow the ligament to work in the right way. There are so many factors influencing results of ACL repair. We now know that it's very important, the type of tear and the tissue quality. As you can see here, the example on the left is a type 1 tear, which is a perfect indication for ACL repair, and the other type is a bad tissue quality of the remnant, a very young patient. It's not possible to catch the ligament with a suture, so this is not a good indication for ACL repair. The coverage of a synovial sheath is very important, as is factors in favor for healing of the ACL. Age of patients, there are many papers showing bad results in very young kids. I found interesting this paper from Dr. Wilson, where again the internal brace can be used to increase and to protect the graft in pediatric patients, and they show good results and no failures. It's very, very interesting. Another aspect for me very, very important is the injury to surgery interval. So it's, we need, for me, a very acute and quick surgery, trying to fix the ligament in the inflammatory phases before it retract, as I told you, and before the formation of the epiligamentous tissue on the top of the ligament, which avoid healing. For sure, augmentation of repair, it's very, very important. We are here in the home of augmentation, of mechanical augmentation, so I don't want to add other words on this aspect. While I'm more confident with protection of the ACL repair with exarticular reconstruction, same as for ACL reconstruction. I work in a university, and it is also a public hospital with an emergency 24 hours. So we see a lot of injuries in the very, very acute phase. So in the last year, we had a great experience in ACL acute surgery in general, and we performed 169 ACL repair. We started at the beginning with very, very simple ACL repair. This is one of the first cases. You see a lot of bleeding inside the joint because it was about 1 week after injury. And as I told you at the beginning, we performed just a simple preparation of the ACL with 2 fiber-wide suture. We performed the femoral tunnel with an outside-in technique as for ACL reconstruction. We like to not to shave or remove tissue on the top, on the femoral stump of the ligament, in order to allow also a ligament-to-ligament healing and not only a ligament-to-bone healing. And that is the results. It's at the end of surgery is very satisfactory because you see like a normal ACL. In the last year, after the introduction of the tightrope for IB, tightrope for ACL repair with internal brace, we started using this device, which is the same device we use routinely for the ACL reconstruction. So I'm quite confident with the device, and this is like an open tightrope that you have to fix to the rings already fixed on the ligament. And then at the end, you achieve adjustable loop fixation for your ACL. This is our actual technique. It's a little bit long video, but it's like a live demo. You see again, type 1 tear, perfect indication for ACL repair, very good quality of the remnant. We perform the 3.5 tunnel on femur with an outside technique. As I told you, we do not shave the remnant, and we use it as a landmark for anatomical placement of our tunnel. Then we use a knee scorpio to prepare the ACL with 2 fiber rings. These are 2 simple rings that are mounted on initially with this suture, which is a shuttle for the device. Usually I use 2 rings for many reasons. The first one is try to catch the 2 bundle of the ACL. The other one is to put a ring proximal and 1 distal. Last but not the least, as for safety, it's better to have 2 rings than 1. Then the first step of the technique is to basically we are passing the tightrope wire inside the 2 rings using the shuttle wire. So you have to put the tiger wire inside, the tiger wire of the device inside the tiger loop of the fiber rings. This is a trick that Tobias gave me when we did the first surgery together. At the end, you have an open tightrope, you just need to close the loop, same as for a BTB tightrope. So this is the step number 2, and the step number 3 is closing the loop of the tightrope by pulling the wire inside the other wire. The tightrope is a wire inside wire device, and this allows us to adjust the length of the loop. So at the end you have a simple device fixed on your ACL. This is a little trick to facilitate the passage of the button inside the joint. We have a lot of wires, the internal brace wires, the tightrope wires, and the tunnel is only 3.5. You can palpate the ligament and fix it and tension it at different degrees of flexion. And the last step is fixation of the internal brace. Usually I put it just in front of the ligament and I fix it on the tibia with a Zwive lock. Ligament augmentation with the IB was proposed by Dr. McKay. That in my mind is very good chance to not interfere with anatomy, biomechanics, or biology of surgery, but just to, as we already see today, protect the graft and act as a bed support device just in case of need after surgery. The brace augmentations should have different characteristics that we already know, but most important is that maybe it allows an early rehabilitation, and this is what we changed after starting using internal brace. We feel a little bit more confident with quicker rehabilitation. Sorry. This is a case, so we remove earlier the brace and we start range of motion quicker. And this is a colleague, a young colleague from another university in our city, which is also a soccer player. 1 month of post-operatively, he had almost complete range of motion, good muscle activation, and a good knee stability. This is an Olympic rower. She had to perform a qualification. So we tried to, with ACL repair, he had an injury, and in 4 months she had a complete recovery of quadriceps strength, and she is now competing for qualification for Olympic Games. This is a case of 1, 3, and 6 months post-operatively. Good healing of the ACL with internal brace. You can see the tunnel of the brace on tibia. And this is another case, 6 months post-operatively. This can be a normal ligament. If you don't look at the Zwive lock on the tibia, you can consider this as a very normal ACL. Showing non-inferior results of ACL repair respect to ACL reconstruction in terms of AP laxity and subjective scores. We recently published our paper. Is a prospective non-randomized study comparing a patient doing ACL repair and ALL repair and patient doing ACL reconstruction and tenodesis. We found not inferior results in terms of EKDC score, AP laxity, and SNQ signal intensity evaluation at MRI. This is an example of ACL repair compared to ACL reconstruction, similar signal intensity at MRI at 1 year. Not difference in patient-reported outcome with a slightly better results in forgotten joint score, and this is very important for proprioceptive preservation when doing ACL repair. 2 failures in the ACL repair group and 1 in the ACL reconstruction group with similar knee stability outcomes. Moreover, we are doing a lot of studies using MRI I know that this is an indirect evaluation of ligament healing, but is very available in Italy, MRI for patient, also in the public system, so it's not difficult for us to perform different MRI. This was a preliminary study on 10 patients. Now we have almost 50 patients. We follow it up at 1, 3, 6, and 12 months postoperatively, showing that the signal intensity improve a lot between 1 and 3 months, and then it's in 6 months, and then it's stable between 6 and 12 months, showing an early healing of the ligament. But for sure, one of the best way to evaluate our results is a second look evaluation. Sometimes it is possible with a standard arthroscopy. This was a case of a patient. She had a pain on the femoral button, so we removed it and we performed a second look. And the other one is in-office arthroscopy with the nanoscope, and we did a study on this. The nanoscope is a sterile kit, including a sterile camera with a 0-degree view and different cannulas and obturator, which can be used for direct visualization of the knee. Procedure is done in local anesthesia using a mixture of lidocaine, ropivacaine, and adrenaline in different syringes. It is possible to perform this procedure in office with the patient completely awake with no problem. We just use some saline solution to distend the joint space. You can use different portals. Most important thing is just to perform a little local anesthesia in the place of the portals. The patient is awake and can participate and look his knee during the procedure, which is about 10 to 15 minutes, to a careful check of all the knee. And in our study, we performed 15. We found 15 patients, volunteer patients, who underwent a second look evaluation after ACL repair. This is a case of a 30 years old male football player. This is the MRI at 6 months, and this is the microscopic appearance of the repaired ACL at the nanoscope. This is one video of repaired ACL. This is nanoscope visualization. You see, for sure it's quite good. If you think how thin is the device, this is a nano palpator. And we, as I told you, we performed this study in 15 patients. We had good results. The microscopic healing was very good in 11 patients and good in 4 patients. With the synovial coverage was good in 10 patients. And also we found a correlation between MRI results and tensioning of the ligament. But the most important part of the study was trying to microbiopsy the scar tissue at the level of femur, and to extract from this very, very little part of tissue collagen and alpha smooth muscle actin and other stuff. We did it in our university with the molecular department. So they used this protocol to extract RNA, and we compared the repaired ACL to ACL extracted harvested from cadavers, and ACL reconstruction with hamstrings, so with tendons. And we found a similar ratio of collagen 1 and collagen 2 in ACL repair to the control group, which is normal. So they are the same ligaments, so they have the same expression of collagen, and it was different from the tissue harvested from a reconstructed ACL with tendons. Another important finding was the presence of alpha smooth actin, which is means that there is a production of fibroblasts in the ACL repair, and the P16 is cellular aging market, which is very, very, very low in the ACL repair group, showing that it's a very vital tissue. We found also a high number of cell positive at alpha asthma, again, meaning that there is a good production of fibroblast, and also the migratory capacity of the cells was very good in the repair group. So this is confirmation that ACL can have healing potential. And so, moreover, recent literature shows that it's not clinically inferior to ACL reconstruction and also can heal with, in a normal ligament, and also that on the basis of our results, the microscopic appearance of the ACL repaired is good. It shows a good tension, good synovial coverage, and also good correlation with MRI signal intensity. But in general, we should not consider this is a new way, but just an option that we all must take in consideration with some clear indication. For me, the key for success in ACL repair are careful selection of patient, as I told you, on the basis of tear and tissue quality, on the basis of age patient, of the age of the patient, and also on the basis of the injury surgery interval that we can have. And protection is very important with both internal bracing of the ACL or lateral augmentation with the LIT, LLL repair, LLL internal brace with different techniques we have available. At the last but not the least, I want to leave you with a message we received last week from one of our patients with his ski instructor. We contacted him for our scores, and he wrote me, this is Italian, but he wrote me that he feel the knee. He can replicate the movement during skiing the same as with of the lateral knee of the normal knee, and this is for me the best satisfaction, because as I told you in the first slide, one of the goals is preservation of proprioception of the knee. Thank you very much.